All right, we are live. Welcome everybody to the Idaho Health Continuum of Care Alliance Conference. We're very excited to have everybody here today. Thank you for joining us. I'd like to start by thanking our sponsors for this session, Project Echo and the University of Idaho. My name is Justin. I'm with Bluebird Health, and I am happy to be announcing our keynote speaker, Christopher Stock. Christopher, thank you for being here.
Absolutely, pleasure to be here.
We appreciate your time and the preparation you've made to get here. So you're an LCSW. Tell us a little bit about yourself.
So I'm an LCSW. I've been with St. L's for over 6 years, almost 7 years. I have a background in biomedical informatics as well. Most people don't know what BMI is, so I figured I should tell you that.
Yeah.
And I've worked in population health for quite a while, for those 6 years, and then I'm actually working in community health and well-being, which is really an extension of that continuum of care that we'll talk a little bit more about.
Okay, exciting. Well, we're very excited to have you here, and thank you for joining us, and look forward to your presentation.
Yeah, well, we'll jump right in and get started.
So,
thanks, Justin. So I'll go ahead and advance. We're going to start this conversation. It's a little bit different format, so I'll go with it. But it's wonderful to be able to present to everybody this morning. Let's see, the clicker is not working, Joe. All right. So that's the cover sheet. We'll go ahead and get started. So how do you define population health? There's a lot of different definitions out there. There's a lot of components to it. In a live audience, I'd actually ask some of you to propose what that definition might be, but I've listed some of the components here, and then I'm actually going to provide a definition for you all. But, we look at data, outcomes, how do we go upstream and actually work through the continuum of care? When I refer to the continuum of care, I'm talking about hospitals being the acute side and then working our way all the way out to the community. Measuring PDSAs, so I'm referencing their Six Sigma processes or lean processes, if you're familiar with those. Plan, Do, Study, Act is what PDSA stands for. Collaborative. How do we do handoffs? How do we work across that entire continuum all the way out into the community? How do we work with home health and hospice? How do we plan discharges? How do we coordinate that? And then how satisfied are people with those services? So we're going to talk a little bit about the triple aim and then how the triple aims evolve, but we'll get into that in just a minute. So I'll go next to the definition of population health and actually what the differential is. And there's a little bit of a difference when I say differential, what I'm calling out there. So we're looking at health outcomes for groups or individuals, including the distribution of those outcomes within the group. So how do we take care of populations of people? That can be defined a lot of different ways. And we'll talk a little bit more about how we do that. So do we stratify? Do we focus on specific disease or chronic conditions? Those sorts of things. So I think one of the things that's important to call out as a differentiator when we're talking about population health is we're being proactive. We're looking at how do we proactively work with members in the community within the groups that we serve. And the other component, and this is the other differential that I called out in the last dot point there, your attributed panel or the attributed population you work with, they're your responsibility whether they come in to see you or not. So that's a little bit of a shift. I think it's sometimes it's a concept between actually progressive, meaning we're looking forward and figuring out how to do things, but we're also kind of going back in time to what was it like when things were a little simpler and we all worked within a community and you had a community health doctor that took care of everything. So thinking of home visits or thinking about how we worked with providers maybe in the 30s, 40s, and 50s. Now, I know I'm looking back and thinking that was all great. And some of us might think that there was complications and challenges then for sure. But that's what we want to do. Within, it's a bit of a dance in population health, but it's also a choreography. So all the services that work with patients and take care of patients and members have to coordinate and be choreographed together in order for that member, that patient, to have a seamless experience. And that's really what we drive for in population health. Next slide, please. So here I just put up some infographics. I thought it would be helpful to kind of look at some images about what we talk about: case management, patient engagement, telehealth. That's a newer piece. We certainly realized over, and this platform that we're in today is actually telephonic or virtual. So there's benefits to utilizing that technology. Looking at analysis. So how do we really look at data? Data should inform our decisions about what we're doing and how well we're doing it. And then clinical integration. How do we take data, information, people, and integrate them seamlessly into the system? So next slide. Let's see if I got it. So the evolution of the aim. So a lot of people have heard of the triple aim, and the triple aim really focuses on, improving the population health. So looking at outcomes, improving the patient experience, and reducing cost. So if we're coordinated and we're working well in a seamless way, that reduces costs. We don't have a lot of extraneous or extra effort or gaps or places where people are falling through. And that really evolved. The triple aim came around in the late 90s, early 2000s. It's evolved. We've talked about the quadruple aim, and by adding that, we're really looking at what's the provider experience? How do we make it easier for providers to do the right thing and have coordinated care and have visibility to what's happening with their patient and the patient population, particularly when you go back to that definition. I'm now accountable for engaging with members and patients, not just 2 blocks in the door. And then it says quintuple, the quadruple aim, and now we're talking about the quintuple aim, which is really adding health equity. How do we make sure that we're providing equity across all populations, all members, particularly those that are more vulnerable? Now, Dustin had me introduce myself briefly. I work in this space now, which is community health and well-being. And in community health and well-being, that's what we're really looking at. How do we take care of the more vulnerable populations? How do we take all that knowledge across that continuum and then take it out into the community and look at what, excuse me, what's happening in the community and how we mitigate and collaborate and convene groups together to actually solve some of those problems. So hopefully that explains those three and kind of the evolution. We're really focusing on the quintuple aim right now. And so that gives you a good reference point. So balancing the scorecard, what is it that you want to look at? Within population health, there's kind of 4 corners that we focus on. A patient experience, we look at quality and outcomes. So HEDIS, I'll talk a little bit more about. Some people know what HEDIS is. It's been around for a while. It is somewhat complicated. STAR scores as well, and then HCC RAF. Those are a lot of outcome components, and payers will focus on those quite a bit. Process and efficiency. How well do we move information across our system and are able to make decisions and put it in front of the right people at the right time? So we'll talk about dashboards, consumable data, standard work, particularly, and then what leverage you focus on. And then financial contracts. How are we set up to be successful? A lot of payers are moving towards population health or have moved extensively into population health and want us to be able to report back on all of these components. So there's different contracts laid out in different ways. Shared savings, upside, downside, and then full risk contracts. And then there's beyond full risk, we also hear total cost of care, in which a healthcare system or an entity takes on the full responsibility of that cost for whatever the member needs. And you have to evolve to be in that space, but there's benefits to working in that space as well. Oops, sorry, I went backwards. Okay, so let's talk briefly about models. I'm not getting in depth on a lot of these components, but I'm kind of giving you a high level view of a lot of these components. So some of the models that you'll hear often in the population health space, patient-centered medical home is a big one. Patient-centered medical home really focuses on that proactive base of care. So your primary care physician becomes the coordinator or the quarterback for your healthcare. If you go to see a cardiologist, that report comes back to your primary care physician. If you go see orthopod for something going on with your legs or knees, that information would come back. So they coordinate that care, and that patient-centered medical home, they know you, they are your reference point, and then they help coordinate that care for you across the continuum. Another model that's important in population health is clinically integrated networks. Those often expand. So if you're in a healthcare system, which is one of the areas that I work in, a clinically integrated network expands the number of resources you have. So you have other independents that are affiliated with your healthcare system that broaden your reach and also broaden the resources that then you can provide to the population. There are agreements and contracts and components that work within that, but the integrated network really expands your network of care. Stratification of populations is another model that we work with in population health, and that's really looking at how do you look at the different levels or different populations and then identify what those needs might be. So I'll give you a quick example. You might stratify and look at your ED utilizers. What's happening with people who are having to go to the ED frequently? Is it that they can't access healthcare somewhere else? Is it because the hours that they work limit where they can go? Is it transportation issues? The only place they can really get to is the main hospital. There's lots of different things. So you would look at that group and then you would start to try and drill down and look at the data. What does it tell you about that particular group of patients? You can do the same with chronic diseases. You can look at diabetes, you can look at COPD, you can look at CHF. And then you look at how you might, what are some of the levers or what are some of the pieces you might want to try to offer or implement to create better outcomes for those populations. Disease management, I already started to talk on that. So really looking at what do you do with certain groups. So for CHF patients, what's the best level of care? How do you set up, we'll refer to it oftentimes as a red, green, yellow or red, yellow, green process. So if I'm somebody that has COPD, I've gone to the ED, I've been seeing my pulmonologist, I have an action plan or I have a pretty good plan, but exacerbations have been a problem and I've been going to the ED, but I'm also supported with care outside of the hospital. Maybe it's home health, maybe it's some other resources. When do I really need to go to the ED? What can be done at the community level? When am I in a green status? When am I tipping into yellow? And when am I in red? So everybody is then working from the same reference point. And then integrated care teams. This is part of patient-centered medical home, but it's also a philosophy and an approach to looking at how we integrate the work. As we mentioned in my introduction, I'm a licensed clinical social worker. So we often say, well, when do we take the head off the body when we talk about physical health care? And by that, I mean, what happened to mental health care? Mental health care is just as integral part of every person that's in our community as their physical health care needs. And one could also say oral health care. So how do you integrate all of that? Where is the intersection for all that work? So in primary care, we've started to integrate and have integrated behavioral health consultants. And so integrating a social worker into a primary care office is in some situations novel, but it's actually really the trend and where everything's moving. Same with a population health nurse, somebody who really focuses on looking at some of the data and then also some of the activities that really help and benefit patients. We're going to talk about transitions of care later. Transitions of care is another big point, and that's really where we see these integrated care teams supporting. We'll keep going. So some of the tools, I told you we would get back to HEDIS. I'm going to drill down at each one of these, but some of the tools and things that we look at are really, and I'll say levers. HEDIS is one of them. And HEDIS, I'm going to give you a definition for, but there's a lot of components to HEDIS. They are constantly changed. They are constantly tightened up and adjusted. And NCQA and through CMS and those different entities, they look at those, and all the payers do. So if you're working with an insurance company or a payer, they're looking at a lot of your HEDIS measures. So, and we'll talk about what those are. STAR scores are a little bit of an extension of HEDIS. It's a roll-up. So they look at patient satisfaction, they look at your HEDIS scores, and then that rolls up and you get a STAR scores, which is a lot more you see in, you'll see STAR scores used in a lot of different venues, but CMS uses them a lot in Medicare. We'll talk about risk adjustment coding, which is an interesting process by which the government's really looked at how do we mitigate costs and expenditures. So they want you to be very specific about how you code and what you code for. And it resets itself. So it's an important process and concept to understand. And then utilization management, that goes a little bit more to stratification, but understanding what's happening within subpopulations or within populations of where you might have overages or higher utilization and why. So looking at those drivers. So we're going to dive in a little bit. We'll start with HEDIS. So HEDIS by definition is the health effectiveness data and information set. I know it's a mouthful. But it's used across the United States. It's a nice tool because it allows us to be on the same playing field. We all know what the measures are. They're defined. They give you exactly what counts and what does not count in each measure. And they're looking at, what are those dimensions of care and service. So for example, I'll just pull one, your A1C. What does your A1C look like? How do we measure that? What counts, what doesn't, what's in range, what's out of range? That's an example of a HEDIS measure. Hypertension, there's a whole list of them. There's 90 of them. You can certainly look it up very quickly. If you're not familiar with HEDIS, I'd encourage you to go and look it up. There's a lot of information on it. It's been around really 2008. I would say it started a little bit earlier than that, but it's really been used extensively since 2008. And it's really to ensure that we're all using the same measurements, the same qualifications, the same inclusion and exclusion criteria for how we measure a particular thing. And that thing being a healthcare related measurement, be it a condition or a frequency, or so breast cancer screening, how often we do that, what counts, what doesn't. It gets into codes and coding as to what actually counts. I'm not going to go into depth on that because it's a whole other topic. STAR scores. So this is really an advent of CMS, and it's really a roll up and looking at how well a provider, and a provider could be home health and hospice, healthcare system, how well they provide the services and how well they do their work. We're all used to STAR scores. I mean, you're used to looking on Google and saying, well, what did everybody say about that product? So it's an easy way to kind of get a sense of, does this group or entity provide high quality? So that's really why CMS moved in that direction. And STAR scores are a big deal because they're a component of those contracts. So we'll talk about contracts a little bit later, not in depth, but STAR scores are part of the contracts. How your STAR score is calculated and what you get year over year really influences how well payers see you and how well it impacts payers in terms of their availability and their ability to access funds that are available. All right, risk adjustment coding. Now we could get in definitely into the weeds on this. We will not. We'll stay pretty high level. But risk adjustment really relies on the ICD-10 and diagnostic coding that represents what the current status is of a member. So And just point of reference, I use member and patient interchangeably because we view them in both ways. And but for a member, you really want to understand what is their current health state. So I'll use myself as an example in this situation. If I'm a diabetic patient, but I'm well managed, I don't have any neuropathy, which would be problems with my feet, my A1C is in control. I'm pretty well controlled. I'm on a lower level of risk. If I'm a more complex patient, I have heart condition, I have diabetes, I have neuropathy, I've had problems with the substance is what I want to say, but problems with circulation, and I'm more complex. There's coding that represents that. Now, the way the CMS plays a little bit in this, so if your risk coding is not accurate, they pay at a lower level. If I'm a higher complex patient, they understand that I'm more complicated and they actually will pay more for that. The piece that's really important about this around risk coding, and you'll hear it at different times, you want to accurately represent your patient population or your patient member and the complexity that they have. You don't want to overrepresent it because you're just trying to inflate it. You want to accurately represent it so that you're paid at the level of the complications or the level of complexity that you have in your patient population. What happens is that you have to accurately do that every year. If you don't, it zeroes back out to the lowest level. And that's part of how it's set up. So there's a couple of reasons why they want you to do that. One, that you're paying attention and you're working with your patient population on a regular basis. You know how healthy or how complex they are. Two, that you're paid for that. If they aren't complex, and you're not doing that, it zeroes out to the lower level. It's a bit of a cost savings component, but there's a piece where you can actually, if you have a more complex patient population, you're actually representing that as well. Hopefully that makes sense. There's a lot of information in this space. There's a lot around coding. You'll hear about different payers very involved in this space. You hear certainly within healthcare systems being very involved in this space, and it's an important component to population health. Okay, utilization management. This is often and I want to step back. So each one of these pieces, HEDIS, risk coding, all those, these are all different levers that you look at within population health. And when I'm speaking about that, I'm talking about a healthcare system. You have to look at each piece. You don't pull all of them at the same time, and you actually evolve through a lot of these spaces as you're doing the work. Utilization management is one of them, where you actually look at if you're identifying, going back to stratification, if you identify that you have exceptionally high costs in a certain area, you would want to drill down and understand what's happening. And so really it's a bit more utilization management's an active process where you're looking at what's happening, what's moving through your system, but you're auditing yourself, and you're also auditing to find variances or pick up on things that may or may not have shifted. And we'll use the last 2.5 years as an example. A lot has shifted. So as we go back and look at what's changed, we all had to focus on kind of stat or emergent issues. So I'm sure pivoting is a term everybody's used, but we've pivoted. Well, as we've moved away and pivoted to things that we needed to do in a more emergent situation, some of the pieces that we haven't been looking at for a while have varied. So utilization management, and I would say auditing ourselves, is a really important component to do. And it tells you exactly what's really being produced or what's really happening in a system. So it's an important process. All right, programs. So these are some of the things that you can focus in on. I just talked about auditing, and auditing really should be a non-event. If you've worked, behavior, I'm going to reference behavioral health. We used to audit ourselves. We would pull charts, and everybody had, a round table, and we'd all look at each other's charts, and we'd look at, all the different components. We had a check sheet of things that we were supposed to be doing. Auditing is a really good way to get a ground level view of exactly what your system is doing. You think you standardized things, you think you educated people on certain components, you think you have certain things tightened up. You'll find out whether that's true or not when you audit. And so a lot of people get scared about, oh, we have to do an audit. An audit really should be an ongoing process that you engage in and look at. And it's a feedback loop, and it's an important component of the feedback loop. So I'm going to move on to the next one, measure-based initiatives. So that's really looking at, this is a little bit more focusing on a chronic condition, but it's also looking at some of these HEDIS measures. So for example, we'll pick on mammography. So mammography rates vary. There's benchmarks that are set. The payers know it. We know it. We know what we should be doing for a patient population. We know how often we should be screening. We know what age ranges we should be screening in. We know what the best screening types are. So how do you build a program around that? Access is often some of the things that people struggle with. So I'll use Boise, for example, or Ada in Canyon County. If I have a referral to somebody for somebody to come in and get a mammogram done, but they have to drive from Canyon County, and I'm making this up, they drive from Canyon County and they have to drive into Boise. Traffic's changed. How do I get to, where am I supposed to go on the hospital campus? There's a lot of factors that may influence that. So your rates may be lower because your access is more congested or it's a bottleneck for you. How do you mitigate that? Well, we've seen the mammo buses, as we call them, going out and about. They may be staged in a public forum, or they might come to a site out in the community. We've often found that if we actually partner them with clinics, it works well, because people are used to coming to their home clinic, going back to that medical home model. I'm familiar with going to where my family doc is. Well, what if we make it easy? What if we stage the bus there, on a rotation? You can just come and get on the bus. We have you scheduled. You can get your mammogram done right there. You don't have to come from Canyon County into Boise. There's projects and programs that you have to set up. And these are measure-based initiatives. So these are special projects that you do to influence your rates or influence your access and create better access points for your patient population, particularly when you notice that there's a miss or there's services that are harder for them to access. Team-based standard work. So we'll talk about, if you get into Six Sigma, and some of you may have had some experience with it, you look at batch and flow. Batch is everything sits in one space, and then one person works at a time, and it goes through, and it can't move down through the system until somebody's picked it up and looked at it. Flow means the document and the work just flows through the system. Standard work's really important because it allows you to flow information rather than batch it. I mentioned TCMs earlier. So TCMs are transitions of care, transitional care management. We talked about being proactive. We talked about choreography. We talked about streamlining the efficiencies. So when you have a transition of care, I'll use myself again as an example. If I've been in the hospital, my primary care physician finds out, oh, Chris was in the hospital, he's being discharged. A nurse from my primary care clinic, or my physician, my doc will call and say, Chris, it looks like you were in the hospital. You've been discharged. How are you doing? Were you able to get all your medications? They'll do actually a full assessment, and then they'll say, your doctor would really like to see you in, depending on what the assessment says, 2 days, 7 days, or even 2 weeks. That follow-up process allows one, for the patient-centered medical home to pick back up on me, but two, mitigate me falling through a crack and being either readmitted or having some sort of an emergent issue show up. This is really important when you're talking about people who have had some significant events or are pretty sick. You want to follow up quickly with them, and you want to have that continuity. So the fact that I'm getting called and my primary care physician already knows that I was in the hospital, or even that I went to the ED and follows up with me, that's important. Advanced care planning is ACP. That's another really important concept. I'm not going to get in depth on that, but advanced care planning is something that we believe strongly is part of standard work and should be done with all patient populations. particularly as people get older. And it's not just completing the work. It's documenting what the wishes are and who's going to represent those. So I'll just touch on that quickly. Huddles. This is really, being proactive again. We encourage huddles in a lot of different spaces. I'm sure many of you on this conference do them, but we look at today, tomorrow, and a week out. The reason we do that is you might need to adjust it. An appointment, you might need to adjust the time. You might need to plan for something to be available if you're doing a procedure. Being proactive makes it a lot better experience and a lot more efficient for a member when they come in. So it's incumbent on us to do that. That's part of that choreography or that dance that we need to be doing. Metric education is the same thing, making sure everybody understands what the metrics are and how they work. Focusing, and this is probably very relevant, extremely relevant for this group, focusing on the continuum of care, hospital, post-hospital, clinic, home, and then SIOH. This is the first time you're seeing this in the slide, but social influencers of health are an important component that we assess for. But it's that continuum. Hospitals starts here, it goes all the way down to clinic, all the way out into the community. And then many of you on this conference are part of all those different community assets and resources. You're an integral part of all that healthcare and support for members. Social influencers of health is a newer space. I believe one of the speakers later here and I were talking before the session started. He's going to talk about community health workers. That is a newer resource, but a very important resource. And that's one that we work with in community health and well-being. Community needs assessments. This is it's work that hospitals and healthcare systems, but not only that, the entire community participates in. So we need to be going out and looking in our communities. What are the community needs? What are the social influencers of health that are active in the community? You can't just look at it from your healthcare's perspective. It's how do you look at that, all the pieces that are coming together. And some might say it's a public health perspective, but it's really looking at what kinds of things are happening in your community that maybe are creating stressors or reducing impact or reducing your ability to work with certain patient populations. Transportation, school, housing, language access. Those are all really important. And then the other one, I'm trying to remember the name, just escaped me, but looking at basically health education. Do people understand? We use jargon all the time in healthcare. Do people really understand what we've just told them? If your doctor says, or your provider says, do A, B, and C, do you really know what A, B, and C mean? So health literacy, that's what I was thinking of. Health literacy is another important component. So, and then food, housing. If you don't have stable housing or you have insecurities in any of those areas, healthcare is not going to be at the same level. If you don't have shelter, how likely is it that you're going to be able to focus on your diabetic care? If you don't have access to food or you're in a food desert and you can only get to one place, that's going to be much more challenging in terms of accessing healthy food. So these are some programs to think about. These are overarching. These are larger concepts that are part of population health. So I felt it was important to cover them. Who benefits from the work? Sometimes when we collaborate, we try and do certain pieces, but we don't get the whole picture. So we really need to look at how we're doing this across the continuum. And, I've illustrated and talked a little bit about our perspective of community health and well-being. So how do we help community partners? How do we convene? How do we look at social influencers of health? How do we partner with other organizations? How do we do handoffs? Those are all really important. When we've talked about population health, and I'm saying we, and within our system, we've always focused on what's right for the patient. If it's the right thing for the patient and it makes it easier for the patient and it makes it easy for them to be successful with their care, they're bettering their outcome, that's the right thing. We have to choreograph all that in the back end. And we have to make sure that that's our perspective, that we're looking at what is the right thing for the patient in terms of their needs and their ability to access and continue to grow, improve their health, or manage their health well. So it's great to collaborate, and we do a lot of that. Sometimes it's hard to quantify. So it's hard to measure all that, but I would encourage you to always think about how can you measure the work that you're doing? How can you measure the impact to your members? How can you build more bridges and convene with others? It doesn't have to be just from your perspective. It's about the community perspective. Patients benefit and systems benefits are sometimes opposing, and that's kind of an odd statement, but what I'm saying is that if you work in a larger healthcare system, or even if you're a part of a continuum, sometimes when you do good work, it impacts other parts of the system and not in a good way. So good way is not the right term. I'll give you an example. So oftentimes in population health, we'd be looking at reducing ED utilization because we're taking better care of patients in the clinic, we're meeting their needs, we're removing barriers, and so they're not utilizing the ED as much. But the ED has certain projections about how many patients they're going to see in the course of a year or a quarter per quarter. So when that's going down, we're cheering and saying, yes, we're doing the right thing, with the EDs not feeling that because their numbers went down from what was projected. That's all I'm saying. Sometimes it's like a teeter-totter. If you pull one thing down, it influences something else, and sometimes that other thing is conflicted about it. Territories and communal, that's really just, being aware that we all work in multiple spaces. Sometimes it feels a little bit territorial, but really the focus on the patient, the member, that's really where it needs to be. And if we're doing that well, then that's really what we want. This is similar to the blue box that I'm going to talk about. Every time you go upstream, you disrupt something downstream. So it's similar to the ED example I just gave you. We often find that the farther upstream we go, and that's really the goal. Population health's goal is to continue to go upstream and mitigate confounding pieces or streamline or create efficiencies in a system. But sometimes there's a desire for things to stay the same. So we've all experienced that, change is not easy for a lot of people, coordinating pieces and shifting to something new. There's sometimes resistance, and that's okay. That's a change management piece. Population health integrates a lot of, I referenced Six Sigma, lean, quality improvement work. That's also about change management. So as you look at this and as you identify pieces, there will be change management aspects that you'll have to engage in, and working with leadership, and working with colleagues that you work with on a daily basis. And data will really give you a good idea. And it doesn't have to be, you don't have to be extremely complex in your data analysis or use of data. If you have convenient data, I encourage you to use that. And sometimes it can be as simple as counts. Sometimes it can be as simple as ratios or percentages. That's a good starting place. You can evolve and slowly move forward and work in other more complex areas as you feel like you're ready to, or need to. But a lot of times simple data is extremely powerful and useful, and you can educate a lot of people. I can't tell how many times I've heard anecdotal pieces shared over and over and over again. And then when you drill into the data, you find that there's really, it is an anecdotal piece. That was one piece that happened, but that story continues to be told. So data can really be helpful in helping with change management. And it should be part of what guides you. It's not the only thing though. Again, going back to what's right for the patient. Remember. So technology and tools. So we've seen a lot of this change. Well, COVID provided a lot of that. This whole conference is virtual. We found out that there's a lot of things that we can do in different formats and forums. Remote monitoring. So if I'm a patient and I'm fairly stable and I have hypertension, what if I remote monitor? And by that, I mean, using technology, you can have a blood pressure machine that actually gathers data, or in some cases is Bluetooth connected and will transmit data to your provider. I have a friend that had heart surgery, and he has a pacemaker. I believe it's a pacemaker, but his heart's monitored continually. He knows exactly what his heart rate is. He actually has it on display on his watch, but it's connected to a piece in here, but it's also connected to his physician in Texas. And if something happens or there's something that's slightly out of range, his physician's immediately notified and he'll call him. So that's an example of using technology, remote monitoring. That's really beginning to emerge. I think there's issues. We have to look at the cost. That's not everybody has access to all those tools or at the same level. But there's great opportunities within that space, and we continue to explore them. Electronic health records are another piece. Having everything in one place. So this goes back, my background in biomedical informatics is all about systems, data, and alignment, and processes about how you develop those. An EHR, a good electronic health record, really allows you to have visibility across that continuum, see everybody who is working with and supporting a member or patient and what they're doing. It's a great way to collaborate. And it's also a great tool for the member, because if you have a support from a good portal, they're able to do that. They're able to actually connect in and communicate, ask questions that they have, provide data. Let's say I've been taking my blood pressure for the last month and I want to communicate what that data is to my provider. I can do that through a portal. And a lot of electronic health records now have emerged. They used to just, electronic health record is almost doesn't fully represent what they do, because they collect a lot of data too. And original electronic health records were just that. They were just electronic documentation file cabinets. They have evolved, and they're actually an integral part, and you can identify, you can communicate, you can reach out to members very proactively through portals. So they're an important tool. I mentioned the remote monitoring, telehealth, expanding that and expanding mobility and mobile clinics. We've seen a rise of that and a shift in that, particularly over the last 2.5, 3 years. But some of that started beforehand. It's continuing. I know that we're continuing to work on and develop mobile clinics. And the reason we are doing that is actually to help and work in areas that we know are completely underserved, or that don't even have access to healthcare, or don't have opportunities to access healthcare readily or easily. So instead of waiting for them or trying to engage them with our system, we take the system to them. So looking at that is an important component as well. Should I keep talking? I'll keep talking. I touched on remote monitoring. So the mobile urgent care clinics, those are an important piece. Those are actually where community needs assessments, going back to those that I mentioned. Those actually help you identify communities that are at high level needs. We have priority zip codes that we know they don't have access to food. They don't have transportation. They don't have ready access that they could walk to or get a bus to access healthcare. So those are ones that we actually look at taking mobile clinics out to. A lot of times, particularly here in Idaho, what you see is around Canyon County and Ada County is that there's a certain amount of population density and there's access and certain amount of services. But once you go outside of those areas, it changes significantly and very quickly. I know some of the other speakers are going to talk a little bit more about what it's like to work in a rural health environment. We see that our footprint within St. Alphonsus is from here to Baker City, Boise to Baker City. So we see that. We see certain communities that are really struggling to have access to services. So we're taking services out to them. We're working with them in those communities. So those are technology tools. There's others. People talked about mobile urgent cares. I know that there's some of the Medicare payers are actually working with a vendor that does that and provides that. And that helps. Home visits, We have certain homebound members that we identify, and we actually take services out to them because we know it's very challenging for them to either get out of the house. And that can be for a lot of reasons, but knowing who you're taking care of and what their needs are is really important. And then how you can leverage any of these tools and technology. I'm not advancing. Oh, sorry. Let me go back one. So population health roles. There are a lot of different roles, and this is not a comprehensive list. This is a list that I'm very familiar with. So some of you on this conference may have other resources or know of other resources that you utilize in your environment or your setting. But this is just a list of some of them. And a population health nurse I touched on a little bit earlier. Within our system, population health nurses are embedded in the clinic. They are working off of those transitional care management lists. So they know all the patients for each clinic that have been in the inpatient and are being discharged. They know who's been in the ED over the weekend. And they look at those lists, and then they actively outreach to those members. They also work on lists that are patients that are due for mammograms or colonoscopies, or that need to come in and get their A1C done. They also teach and train in the clinics. They help support those clinics around how do the measures work. So they do the metric education. They do the advanced care planning. They often meet with members and actually complete all that documentation and work with them, as well as other members in our system that do that. The pop health medical assistant, they help tee up a lot of things. They will tee up components, and they're embedded in the practices as well. So that's an example. Behavioral health consultants I talked about, these are social workers. Their role is not to get into and provide long-term counseling in a clinic setting. Their role is really to be that warm handoff. So if a provider identifies somebody that's struggling, and it may be situational, it may be something that they've been working with for a while, and they notice that they've been working with them, but they're still struggling, and they feel like the provider feels like it would be really helpful to connect them with a social worker. The social worker is not going to do long-term counseling, but they're going to connect with them. They will be a constant for them at the clinic. And then if they need longer-term counseling, they would connect them into the community. They can provide that linkage and also remove, a lot of people will talk about a stigma that's in place for, oh, my doctor gave me a referral, I got to go see the shrink at the behavioral health clinic. And we know that a lot of people won't make that drive over, or that's suddenly a stigma. But if I can do that in my primary care clinic, and I can see the social worker and talk with them there, and they have ideas, and they may do brief counseling components with me there and see how I'm doing, and I can always check back with them, or they'll connect me with other community resources. Or you'll see a community health worker, they do a handoff to a community health worker and say, I can work with you on these things, but I'm going to have a community health worker work with you on some of these other social influencers, like some of the stuff you're talking about, getting signed up for insurance, or your housing insecurity, or you have transportation needs, those sorts of things. The behavioral consultant will work on some of the social aspects and the behavioral and mental health aspects, and then parse the other work to the community health worker. Ambulatory pharmacists. I haven't touched on them until now, but ambulatory pharmacists are extremely important. And the reason being is that medications are extremely complex. And even providers, that changes the number of medications when somebody went inpatient and then they get transitioned to an outpatient. We use ambulatory pharmacists as much as we can. We wish we had more, I think, but they're very, very helpful in terms of understanding, looking at all the different medications, and then supporting the care team about what maybe are some good changes to make. And sometimes, people will come out of different situations in different settings and be on different medications when they went in, and maybe some of those are good, some of those are contradictory or contraindicated. Complex care managers. These are often for people who have more complex care needs, maybe have complex diagnoses, or have gone through some complexity, perhaps an accident, injury, or a complex surgery. And so they really stay in that space. They usually work with members for around 90 days and then reassess, but they're really there as a linkage to support the more complex care needs that a member has. And then discharge planning. I'll come back to risk adjustment coding in just a minute, but discharge planners also work in that space about making sure that everything's prepped and ready for someone who's leaving the hospital or transitioning from one situation to another, and making sure that the next players know what's happening, and that if you think of it of a relay run, they're ready to hand the baton off to the next group. Risk adjustment coders are also important. We touched on those earlier about risk adjustment coding. That's really where you want to make sure if you have complex patients that you're representing that accurately about the complexities that they have, and that you do that at least annually. So these are some population health roles. They're not the only ones. These are ones that I'm more familiar with and that I've actively worked with and engaged with. Community health workers is probably the newer one. You're going to hear a little bit more about that later. It's a really unique and interesting role, and it's extremely helpful to partner in the community, and they become your eyes and ears and your feet on the ground. So an important role, but that one's evolving. It's evolving here in Idaho, and I think many groups are trying to figure out how to stage and best utilize them and then integrate them into their systems. So I think my next question is what I miss. So this is where I'm going to engage you all online. If you have questions for me, we have a few minutes. I think we have about 8 minutes left. But if you have questions for me, please ask. Or if there's components that you feel like I've missed that are really important that you'd like me to comment on, or that you'd like to be brought forward, I can certainly comment on those. She can hand it to me. It's fine. So
we've got some questions from chat,
oh yeah, okay.
and I figured they could just pick me up.
Yeah. Ruth's going to help. Ruth's going to help me here. Ruth's going to read the question to me, and then I'll respond to you all.
So consumer engagement with technology, with owning responsibility for health literacy, what kind of strategies are effective in terms of helping the patient member be fully engaged in the care that you are offering them?
So that's a big question. So it depends on which piece. So if we're talking about meds and health literacy, those pharmacists, those ambulatory care pharmacists are really helpful in that space. There's meds to beds programs that often hospitals are engaged in. So making sure people have their meds before they leave, and that somebody has an opportunity to talk with them about exactly what those meds are and how they should be taking them. That's an example of that. In terms of understanding what's happening with their care, let's say I'm a diabetic. What does that mean? You just told me I'm diabetic. I don't even know what that means. What am I supposed to do? So in those situations, referring them to an educator or a specific program can be very helpful. We have a diabetic program, and I know not every system, not everybody has access to all these resources, but making sure that they understand what you just told me I'm diabetic. What does that mean? Explaining exactly what that means, what's happening in your body, what kinds of things you're now going to really need to be careful about or keep track of, and that you have help and assistance in doing that, it's a partnership. We're not going to just say, oh, you're diabetic here, good luck, we'll see you. We'll see you in 3 months. But what does that really mean? What are some of the activities that you need to start doing? What are some things that can help you? So in our program, we refer them to the diabetic clinic. A diabetic educator works with them. They will talk with them about food. They will talk with them about quantities. They do a whole dietitian component. And then they will talk about activities that are beneficial. And then what does this mean for your life? If you've just been diagnosed as a diabetic, what does that mean? What do you need to start looking at? And then what that trajectory can be, not to scare people, but what that would look like overall. So hopefully that answers your question. So what others?
Yeah, we have a question from Stacy, who I just lost.
Okay, Stacy's got a question, but we're getting to it.
Thanks.
Bear with us, we'll get there.
How is the hospital helping to share that a patient has been in acute care and needs follow-up? There are times where the primary care doctor doesn't even know that a patient's been seen in an emergency room. So what are the ways in which that communication can be improved?
So there's a couple different processes for that. And I don't know that I have a one size fits all. There's two things that come to mind immediately. One is there's a program called Collective Medical that we utilize. In Oregon, I believe it's called EDDI, but it allows you, and you can get notification actually when somebody accesses the ED. So anytime someone accesses an ED, you would get notified, and you can actually keep an eye on certain patients that you know that you maybe have a plan set up with, that they should call you or connect with you prior to going to the ED, but if they showed up at it, or they show up at multiples. Sometimes we saw that previously where people would go to different EDs for different things, that you can actually monitor that, and then that way you can partner with the member in that. The other place is an EMR, an electronic health record. A lot of times will allow that information. We used to, before we were on a fully integrated one, we would have to pull reports, and we set those reports up with the data folks and coordinated with them, and that report would be produced every night. And so we would know who touched someplace in our system. We didn't know who touched outside of our system. So there's limitations to it. It can be challenging. I think Collective Medical, EDDI, the EDDI program, those are two that are multiple states, and they allow you to, and they will provide, and they're not super expensive, but you have to reach out and kind of understand what that process looks like. But they can provide information and transparency about who's touching EDs. Now, if it's transitions and leaving one hospital, they had surgery at this hospital, and you don't have visibility to it, that gets a little bit trickier. So you have to really do a little bit more legwork and coordinate. What else? Looks like we're gonna wrap up.
Yes.
We're wrapping up. Okay.
Hey, Chris, that was awesome. Thank you.
You're very welcome.
I
Pleasure.
mean, so my question, I have a question for you.
Yeah.
How do I book more time with you? I'll just email you directly. Let's hang out.
You can email me directly.
Okay.
So it's christopher.stock@stalfonsus.org. You can get a hold of me that way.
Great.
I'm happy to answer more questions if people want me to come and speak about some other components of it. I'm happy to drill down. I tried to keep this at a higher level.
Sure.
And cover some of the major concepts, but I know that there's pieces that I didn't, and there's probably other questions that people have.
Yeah, no, clearly there's a depth of knowledge here that we'd love to glean from it. So we certainly appreciate your knowledge, expertise, and the presentation that you've done today. Thank you so much. Awesome stuff.
You're welcome.
Awesome stuff.
Pleasure to be here.
Yes. We're going to take a quick break now. There is a break session. We want to give you a few minutes to answer some emails and make a sandwich. So we will be back shortly with our next presenter. Thanks everybody for joining.
Thank you.